We now move to the next session, microbial infections, challenges and way forward. Please welcome our session chairs, Dr. Siddhartha, Assistant Professor, Department of Biotechnology, Pondicherry University, and Dr. Supraja Srivastava, Professor, Department of Microbiology, Christian Medical College, Vellore.
Welcome to the session on microbial infections, challenges and the way forward. I am Dr. Supraja Srivastava. I am a professor in anatomy in CMC Vellore, and along with my co-chair, Dr. Siddhartha Bosi from the University of Pondicherry. It's a privilege to chair this session. We know that microbial infections remain a pressing challenge both here in India and globally. In this regard, we have three very interesting presentations lined up for you that are going to deal with various aspects of this evolving field. So, it is my privilege to introduce Dr. Balaji Veeraraghavan for the first talk. Dr. Balaji is Professor of Microbiology at Christian Medical College, Vellore. His research focuses on antimicrobial resistance, multi-drug resistant pathogens and vaccine-preventable bacterial infections. He leads national surveillance programs, contributes to WHO advisory boards, and has published extensively on infectious disease control and quality assurance in microbiology laboratories. Today, Sir will talk on newer molecular approaches in infectious disease diagnosis. Please join me in welcoming Dr. Balaji. Thank you, sir.
Current molecular diagnosis trend in microbiology, why it's important is definitely over the last 5 years, post-COVID, you all know that after HIV, the ELISA become more popular and it has become like in use in almost every center. Post-COVID, the genomic sequencing has become very common and popular among all the microbiology lab. So that is one reason where the technology was available. And second thing, which pushed to molecular diagnosis is now antimicrobial resistance. Because earlier only one beta-lactam was there with carbapenem or cephalosporin to combine, only tazobactam was there. Now almost now 10 different beta-lactamase inhibitors are there, and their combination is to be used for precise therapy. Unless you know the resistant mechanism, that cannot be used appropriately. So the antimicrobial resistance and the COVID pushed the molecular diagnosis to the forefront, and it has become more common these days after COVID to use the current molecular diagnosis. So another reason is the turnaround time is very short. So for this reason, this is becoming more and more popular. So what I am going to talk about is multiplex PCR, how this is improvising of the multiplex PCR panels, and beyond multiplex PCR, targeted next generation sequencing is happening, then metagenomics, next generation sequencing. And usually you know that to pick up tuberculosis, that is the best example I can give. To improve the yield and specificity, we have a prior step called preparation. Remove all the host cells and selectively enrich the bacteria, and so it becomes easy for us to pick up the organism, identify and do the susceptibility. Similarly, before subjecting any clinical specimen for molecular work, we need to do a preparation where the sensitivity and specificity can be improved. So with the next generation sequencing, the key secret to improve that sensitivity specificity is preparation. So those preparations are ultra enrichment of the clinical specimen, enrichment of the target capture and circularization technique, then amplification of the circularized DNA, then whole genome enrichments. So there are many different preparations are there. So unless you do that, you may not, the desired outcome cannot be achieved. And sometimes during the sequencing itself, you can, with the machine algorithm teaching, you can improve the sensitivity and specificity. So I'll be informing all those techniques today. And these are all the two common approaches which we do. One is the nucleic acid amplification technique. It's a simple only PCR, only the targets will be identified. Whereas in the next generation sequencing, beyond the identification of the bacteria, it will include further information on the species, virulence factor, antimicrobial resistant, lineage, clonal. So many other informations can be derived from the next generation sequencing. You have to choose for your clinical diagnosis what is important. Only identification is good enough, then stop with NGS. But if there is an outbreak or if there is an incidence increasing in your setup, then you want to have additional information, then you have to go for the next generation sequencing. And now what are all available is on the bedside molecular diagnosis are there for upper respiratory infection. Within 15 minutes, you can have screen upper respiratory tract for following bacteria and viruses. And it's a bedside test. Within 15 minutes, we have with the highest sensitivity and specificity all this. And this has become a mandate for every hospital to have the screening test so that the antibiotic is not misused or overused for upper respiratory tract infection. So one example I have given, and for Flumarae pneumonia panel, you can look at bacteria, semi-quantitative. You have all the commonest or almost 95% bacteria causing pneumonia are covered here. In addition, atypical pneumonia is also covered, that is Chlamydia, Legionella, Mycoplasma. It's a semi-quantitative. All the common viruses, and in addition, antimicrobial resistant markers also identified. And this is because you know that respiratory, as it's not a sterile area, we are not sure certain amount of colonization bacteria contaminating are there. So to differentiate colonizing bacteria from the pathogenic bacteria, they have a system to quantify. So anything less than 10 to the power of 4, it's considered as colonization. It won't report. Anything above that, it will give the quantitate. The highest number is considered as pathogen. So that's how, and all the guidelines also has given a threshold how to determine and report the semi-quantitative pneumonia culture. And it has gotten a great sensitivity or specificity, especially from the ball and the sputum. And then meningitis panel is there. More common bacteria, viral, and common fungal can be identified. This all can be achieved within 1 hour directly from the specimen. The question is, it's only the affordability. Even we have, each test costs 15,000 rupees. So we have, because the tertiary care, so we can bring in access is definitely there in our center, but many centers, they don't have access to this expensive test, and affordability are the two determining factors. Otherwise, very good sensitive specific tests are available where you can pick up very early. And there are many number of panels are there with the specific ID of the organism, panel of organisms and resistant markers. So according to your need, you can choose the kit. And now this is the current one in India. So many panels are available, and with the greater sensitivity specificity you can see, and you can see the sensitivity specificity almost 98% to 99% sensitivity and specificity. And this, the entire list is once the blood culture flags positive, from the supernatant of the flagged blood culture positive bottle, we do that one. So you have to wait till the blood culture flags positive, which usually takes 24 hours. Though we incubate for 5 days, 80% of the blood culture will flag within 24 hours. And within 1 hour after it flags, you can identify the organism. But only thing is, you need to have a 24/7 lab. Soon it flags, then you have to do. Because we have a huge volume of blood culture flagging positive, in real time that doesn't happen. Even still the delay of 2 to 3 hours, even sometimes 6 hours. After hours, it even becomes 12 hours. So that's the problem. If you want to have, and there are certain kits are there where for cheaply available. I would like to highlight, when you are choosing the kit, what is more important is you need to have a good volume. If you have a less volume, then the sensitivity specificity drops, and the lower deduction of threshold is another important thing. See, this is a Turkey kit which is widely used in India. You can see the 100 to 500 colony forming units is the threshold they have. But whereas there are certain kits which has got a threshold of 3 to 4 colony forming units. So that is what you have to prefer. Those sensitivity specificity will be much higher. So two things you have to look in. One is the volume of the blood to be collected and lower deduction of threshold. So these two are important ones. And now I will move on to the blood culture. I will give one as a template. Blood culture is an imperfect tool for a deadly condition because it captures only 30 to 40% positivity rate. The rest are all contaminated. And false negative is due to one important is contamination, prior antibiotic use, and sometimes a fastidious organism, or inadequate blood volume, or lack of sensitivity due to low number of copies. So there are many number of molecular tests are there where closer to 100% you will get positivity. And one among that is it's called T2 bacteria. You don't need to wait for the 24 hours of blood culture positivity. You have to draw the blood, inject into the blood culture bottle, it has to incubate, then it has to flag positive, then you identify the organism. Here, instead of enriching in the blood culture bottle directly from the blood, like cell counts you do, you draw the blood and put it in the machine, within 3 to 5 hours, it gives you the answer, organism. And the commonest escape pathogens, Staph aureus, E. coli, Klebsiella, Pseudomonas, Acinetobacter is picked up. And this is FDA approved. And look at the load of detection. It's 2 to 11 colony forming units. And even the resistant mechanism, it gives you within 5 hours. And limit of detection is 3 to 11 colony forming units. So this is one. And there are many number in the pipeline which will be available in the next 1 to 2 years. There are half the things have been filed for FDA clearance, and already in India few kits are available. And I would like to draw your attention to the first row. You can see the Genie sepsis pathogen kit. The blood volume is 5 ml, and the limit of detection you can see bacteria 3 to 4 colony forming units. We have evaluated this and we found it's really working well, and the sensitivity specificity is 100%. So, can we do this alone? No, definitely this should be accompanied with the blood culture, so that we know that false, because blood culture positivity will be much lower than the molecular positivity. And if you want susceptibility testing, then you need to have the colony. That's the reason purely culture alone we cannot depend. We need to have molecular diagnosis also accompanied with the culture. And for most of the molecular resistant mechanism, if it is plasmid mediated, it can pick up. Genes are there. But for chromosomal mutations and all, it can't pick up. So you have to have a phenotypic determination to have. So that's the difference. So always this should accompany with the culture. And another one is T2 biosystem, which I mentioned to you earlier. And there are certain things, Septifast, though it had good, wherever the volume is low and the threshold is low, your sensitivity specificity will be compromised. This is directly from the blood. And another latest, after COVID, what has happened is we were depending largely on the lactate, procalcitonin and CRP. Now there are 3 FDA approved kits are there, which is a good biomarker to differentiate between sepsis and non-sepsis, infectious inflammation and non-infectious inflammation. Those kits include, these are all the FDA approved markers. So SeptiSite Rapid it's called, within 1 hour it gives you the result, and they look for it's a PCR based, measures for messenger RNA expression levels from WBC markers, PLA-C8 and PLA2G7. So this is one FDA approved kit in 2024, and Tri-Variety is the another one. Here it's again PCR based, but in isothermal. Thermal cycling is not required. Here the advantage is, there it's only 2-3 markers. Here it's 29 host markers. The sensitivity specificity is much better, and this also picks up within 30 minutes. Earlier it was 1 hour, this is within 30 minutes. And this has been validated in emergency department across Europe and America in more than 22 centers. So to summarize, the third one is IntelliSep. It's another one. It's not PCR based, it's cytometry based. And you can see it's almost everything has got above 85% of sensitivity and specificity. And the last one, cytometry, within 10 minutes you will get it. It's all point of care test. So this is another new thing which is happening beyond the lactate and CRP and procalcitonin, so that the misuse and overuse of antibiotics can be reduced. And the fourth very interesting is, now to predict the sepsis, FDA approved machine algorithm based, it collects all the information of the host factors or organism, susceptibility, everything, and it predicts. And this has been approved, and definitely it shows with this there can be an improvement in the patient condition when you intervene according to the score which it gives. So again, this is FDA approved ML assisted scoring system, and really this helps. So there are many numbers, such numbers are available, and this is the first one to get approved by FDA. So now I move on to tell you about the difference, how we are improving our diagnostic reporting, moving beyond multiplex PCR. So both are predefined. The targets we know. In multiplex PCR, usually 10 to 20 targets, organism targets, signature we capture. In targeted metagenomics, what we are doing is, we can go beyond 20, close to 1,000 we can go. So we can go for the organism, genus, species, virulence, clonality, or resistant mechanism. You have a huge range, up to 1,000 you can go. So that's the metagenomics. And the sensitivity with the multiplex is only for the targets it will do, whereas the targeted metagenomics, low abundance also it will pick up. That's why the sensitivity also will go up. So there are many number of kits are in the market. You can see for Escherichia, it's all individual organism is also there, and for panel also it's available. And you can see if it is targeted, only 5% of the genome is covered, and 95% coverage it's there. That's how the sensitivity and specificity goes very high. It all depends upon the target which you do. If it is a toxin producing, then look for the toxin, you will get the answer. So it all depends upon the targets. And with a high suspicion, you can use these kits. That is for epidemiology. For AMR, again for the organism and the region, a short region, and most of the information which you required, desired, can be picked up. So this is for the AMR. So you name anything, I can generate a table. So much are available now. Especially that's why I'm saying after COVID-19, lot of informations can be gathered from moving away from the multiplex PCR to the targeted next generation sequencing. Metagenomics is too much. You will take long hours to interpret that information. But the targeted ones are very easy and with more information. And to improve our next generation sequencing, so there are many number of enrichment methods are there, where you can improve the sensitivity and specificity, and within few hours you can get. And there are many number of pipelines are there. Within 1 to 2 hours, it will analyze and give you the answer. Otherwise, generally it takes 3-4 days to read all the huge amount of data it generates. And directly from the blood, if you take, the biggest challenge is preparation of the sample for sequencing. What happens when you draw the blood, you have the input ratio of 2 billion human cells, host cell, to 1 microbial organism. So this has to be prepared in such a way that to bring the microbial billion into few hundred, and 1 microbial should be 1 human cell. Almost all the human cell needs to be knocked out. So there are many number of high enrichment preparatory kits are available. You have to choose and standardize in the lab. That is the secret. And if you do, the first column is host is 99. You remove that, then you pick up 1% bacteria. Second way is, these are all the few kits are available where you completely knock down all the host cells. You pick up the targets, and new additional targets also you will pick up. But if you do selective lysis and differential methylation host cell, retain some host cell means, then the pickup of the organisms will be much more. The rare ones also can be picked up, that blue, green, which is not present in the second one, in the third one it will be there. So enrichment technique, it's based on PCR, it's their target, then amplicon amplification is there, then you can sequence it. That is another way. Then hybridization, probe capture is there. Then CRISPR-Cas enrichment is also there. So there are many number of approaches are there where you can enrich. It all depends upon the organism pathogenesis. So based on the organism nature, tuberculosis is a different, because see, organisms are different personalities. Nemo behaves differently, Salmonella behaves differently, TB behaves differently. You may think all are organisms, but every organism is an individual personality. They behave differently, and once you know the pathogenesis and its behavior, accordingly you can tailor to capture that one. And when there is very least number of copies, where even multiplex PCR and targeted NGS fails, still they have refined techniques even to capture to the very low level numbers. That is called molecular inversion probe, where you have a universal primer, but the probe for the target you have to design. And then you have to amplify it. Then you will have circularize that molecular inversion probe. So this is the ultimate, where even where the next generation sequencing or multiplex targeted are missed. And this is becoming more and more popular, and hereafter for diagnostics to have much better sensitivity and ease of handling, I feel that PCR will be replaced by rolling circle amplification. So what happens here is, here the linear DNA strings are converted into circular, and in isothermal condition, it can move, amplify much faster, and the yield will be 15 times more than the PCR. So that's the reason the PCR hereafter will be replaced with rolling circle amplification. So now other way of doing is, suppose one best example I can give you is in tuberculosis, in tuberculosis suspected patient, in the sputum you will have Mycobacterium tuberculosis. At that time, we would like to enrich the entire sputum sample to give more number of bacteria. So what we will do is, we will prepare the bait to capture all the broken Mycobacterium tuberculosis. Then connect it to everything, then you will get the full sequence. So directly from the specimen, how to enrich, this is called circular nucleic acid enrichment reagent synthesis. CERN it's called. And you can do that way. And this is another way of picking up even the Mycobacterium tuberculosis. So I told you these are all prior to the next generation sequencing you need to do. While doing the next generation sequencing, when it is amplifying, there also you can intervene. That is called as adaptive sampling in nanopore sequencing. This is available only in the nanopore platform, not in the PanBio or Illumina. Here what happens is, when it is sequencing, you teach the machine that what you are interested in, what is your interest targets are there. Once the machine learns your interest target, only those targets will be amplified. The unnecessary, unwanted sequence it won't amplify. That way it gets adapted to the selective amplification. So that is possible with the nanopore. So they are exploiting this technique. In real time you will have the answer. So basically you have to teach ML, and it works like sequencing the matched target. That unmatched targets are rejected, and this is the uniqueness of the nanopore, adaptive sampling nanopore. Suppose you have a suspected Helicobacter pylori in the gastric biopsy, then you want to selectively amplify only the Helicobacter pylori from the tissue. So when you teach Helicobacter pylori capture signature to the machine, only when it sends that particular target it will amplify. All the host tissues it will reject. So in real time, within few hours, you will have the answer from the biopsy. So that is called adaptive sampling in nanopore. And there are many techniques which I have explained to you. You mix and match for an individual interest, you will get a surprising results. So there are many number of, one example is do the molecular inversion probe and combine with rolling circle amplification, you get highest sensitivity specificity. So there are many such combinations you can try and improve the diagnostic kits. And now I move on to the last component, metagenomics. So this is the long list of commercial kits which are available in the market. And I would like to highlight the special features available with the different kit. So here you can see cell-free DNA whole genome sequencing happens in this kit. In the next kit, not only the bacteria, even the host response can be picked up with the messenger RNA sequence. So both it's possible with this kit, pre-digen kit, and it's expensive sepsis. And zero diagnosis same, and this one is also nothing different. If you look at the Medi Analytical, it has got artificial intelligence inbuilt. So the turnaround time interpretations are much faster, and it combines both messenger RNA expression levels as well as the organism cell-free DNA sequences. So it combines both and gives you the result. So even the kits with the metagenomics comes with the added features to have the complete information on the infection at the early. So with that, I would like to end my talk. And already many number of kits are available, and they are commercially, they are providing service. But not in every center, they have core facilities. You send the sample and the results are sent by within 24 to 48 hours. So with that, I would like to end my talk. Thank you very much.
Insightful presentation from Professor Balaji, CMC Vellore, on detection of pathogen and resistant markers using culture independent techniques. Now it's open for discussion.
I can talk loudly. Balaji, I had one question. You mentioned about PCR-based diagnostics from non-sterile sites.
Yep.
Now there is increasingly companies which are providing multiplex for AMR also, but from a non-sterile site, without deconvoluting using NGS, how will you attribute that to the pathogen, whether it's a cat?
Yeah, it's very difficult from a mixed sample to identify. So it can be from a commensal flora, you can pick up AMR. So with the caution, you have to interpret. So that is the disadvantage in the system. So if it is sterile area, no issues, as you said. If it is commensal, it's going to be a problem.
Thank you, Balaji. Wonderful talk. And nice to see that there are so many alternatives to blood culture, which, is cumbersome and also needs facilities. You talked about this bacteria 2 or BAC2 or something.
Yes,
which is FDA
T2
approved.
bacteria.
T2 bacteria. But then when I looked at the tabular column which you had shown, it says the technique used for that is magnetic resonance.
Magnetic resonance.
So,
Still it's
for
not
my
available.
knowledge, magnetic resonance means it will be a spectra.
Spectra.
And
Something
you'll
like
be
an
looking
MRI
at,
does
so
it.
you'll pick up something like either lipid or glycogen or something of that sort, right?
Correct.
So are you looking at the cell membrane and you have characterized the lipid quantum or the configuration of the lipid on the cell membrane when you use lipid spectra?
Exactly.
Are you doing that?
No, it's
So
the
have you
machine does
reached-
everything.
And have
It's
you
a closed
reached
system.
the level of specificity and sensitivity for every bacteria as far as its cell wall is concerned
Culture.
to get that degree of accuracy?
Yes, sir.
Okay. Amazing.
That's why they could not achieve to a big panel of organisms. The most common escape pathogens alone it's there. If you look at the blood multiplex PCR or targeted NGS, you can achieve for thousands of bacteria at the same time. Whereas this particular magnetic resonance has been standardized only, they could achieve only for the most commonest organism.
But this
Only handful, 5 to 6 organism.
But is it? Would this be available at a remote set? It's going to be difficult,
in
right?
India, it's not available.
The technology for magnetic spect is still a little cumbersome to get down to the level of something portable or small.
That's the difficult thing.
Right.
It's only in big centers, Ivy League colleges in the US they have. It was invented by MIT and Harvard. Now it's available in the south, in Berkeley, in this side Yale, and only the top universities and hospitals are having that system. It's quite expensive. That's why in the beginning I said, accession should be there. First, in India, nobody has got, and affordability also should be the better. So, as of now, techniques and systems are available. It's the question of people bringing this infrastructure to the country and people willing to spend more money on the diagnosis.
When I saw the first slide, I said, okay, mission hospitals. When I saw magnetic spect, then I said, no way.
Thank you, sir.